All right, so 3:20 p.m. and we will start with Dr. Goyal's presentation.
Good afternoon. This is Pawan Goyal from American College of Emergency Physician. So ASAP is building an emergency medicine data institute as a treasure and a resource for the community, where we are collecting data from more than 1,000 hospitals on daily basis and trying to create experience report and understand, why patients are coming to emergency department and what are the trends and variability that is happening over time. This became very evident during COVID. So the current poster is really around 2021 data experience and what happened during the COVID to the emergency department visits, as well as the deeper dive into those visits. So a little bit about the Emergency Medicine Data Institute here on the left. The Data Institute is built upon 3 pillars, and they are essentially collecting and utilizing data from various clinical episode of care, as well as the billing data, such as the ICD-10, CPT-4 codes, etc. So the first and the foremost purpose is to enable research and surveillance and population health in the community. Second is to help with our emergency physician compliance with various governmental and non-governmental programs such as MACRA and MIPS compliance, quality reporting, Joint Commission compliance, etc. And the third is to enable a lot of new innovation such as analytics, utility apps, AI, modeling, machine learning, where data is important to test any new model. The registry platform is known as CEDAR, or Clinical Emergency Data Registry, which is a specialized nomenclature given by CMS that is approved for compliance to merit-based incentive payment system. The registry platform started in 2015, and between 15 and 21, in 6 years, it had more than 100 million visits that were collected, representing 30 million unique patients. In terms of the number of visits and type of visits that were happening in 2021, so there were 18.3 million visit data that was collected in 2021. And the number one reason was COVID-related 1.3 million visits. There were essentially others such as hypertension and drug therapy, etc. But the key findings are here on the right on the graph, that when the visit volume was reduced because of lockdown and shutdown, etc., there was a big reduction in essential care, such as patients coming with heart attacks, trauma, and other conditions to emergency department, especially around geriatric and pediatric population, as well as some of the non-essential things like dental pain visits were drastically reduced. Happy to share more detail or respond to any questions during the Q&A answer. Thank you for having us.
Hi, everyone. I'm Nikki Gotro. I'm here representing the Clinical Decision Support Innovation Collaborative, which is an effort funded by ARC. And today I'll be talking about real-world measurement of PCCDS, which is clinical decision support that focuses on patients and caregivers' needs and experiences. This is relevant to the mission of MCBK because by understanding and advancing measurement for PCCDS, we can move to computable formats that better engage patients with their care. So we did this by first selecting 20 ARC-funded projects and reviewing their published reports for how they were measuring PCCDS. Then we selected 9 projects to conduct key informant interviews to ask them about the measures they use and any challenges they experienced with measurement. We then synthesized all the findings to develop key themes and an action plan for advancing PCCDS measurement. On the right, there are 4 graphs that show a high-level overview of the selected studies. So many of the studies use tools to address chronic conditions and had patient users as a user population. And many also collected patient-reported outcome data using mobile apps or electronic health records. Moving to the middle, we summarized the common areas measured by the studies. Overall, usability was the most common area of measurement, but as you would expect, assessments differed by the phase of the project. And Despite how frequently it was measured, key informants also expressed challenges with measuring usability for populations with limited digital health literacy or English proficiency. Another common area of measurement were patient-centered measures, but we found that they were mostly to understand process measures like the satisfaction or engagement with the tool, and not as much to assess the outcomes, like how the tool impacted patient activation to manage their care. As for gap areas, very few projects formally measured the safety or timeliness of the technology, but when we spoke to key informants, they said they did measure those informally in the development process. And finally, few projects measured equity beyond just collecting demographics or the cost of developing or deploying the technology. So all these findings and recommendations led us to develop 4 key action items. First, there need to be more evaluations of real-world operational projects in diverse healthcare settings in order to observe the use and impact of PCCDS. This would help develop measures like costs and technical performance that are critical to the adoption of new technologies. Second, we need to identify more standard measures and interpretation of measures for the performance and acceptance of different technologies, like apps, wearables, and patient portals, to understand what technology works and for whom. Third, we need to adapt tools and methods for people with limited digital health literacy in order to better engage that population with their care. And finally, more work is needed to measure the impact of PCCDS tools on equity and long-term health outcomes. And that might require longer timeframe studies or new ways to measure health outcomes within a given scope. So thank you for listening, and please use the contact information at the bottom if you want to learn more.
Greetings, everyone. I'm Jerry Osheroff, and the work that I'm going to be describing is about identifying care gaps to drive clinical quality improvement. And importantly, making the point that interoperable, computable, biomedical, knowledge-enabled approaches to this work are urgently needed. I'm sharing this work on behalf of a bunch of collaborators, several of whom are in this meeting, who are participating in 2 different learning health system learning communities, one focused on pain and opioids, one focused on sickle cell disease. Next slide. So the next slide. So the context for this work is that understanding gaps in care is essential to drive clinical quality improvement and learning health system efforts on these targets. So since 2022, there's been a pain management and opioid use LHS, a learning community that's fostered collaboration among care delivery organizations, EHR vendors, many other stakeholders to accelerate quality improvement for this target, including developing a pain and opioid care gap report. The participants early on in this effort identified that in order to move the quintuple aim needle related to this target, it was going to be essential to identify where the ball was getting dropped in specific care delivery organizations. So we identified 12 important targets that could represent these important care gaps. So things like patients on very high opioid doses, multiple emergency department visits, et cetera. So we identified about a dozen of these gaps that we wanted to enable care delivery organizations to assess. Next slide. So what we actually did very early on in the effort, Dave Little, who's in this group from Epic, developed with Epic support a query that could identify patients meeting these specific criteria. These query needed to be implemented by people with special training, and the results produced in order to configure the query, it required expertise to do that as well. So later last year, Epic released a much more sophisticated care gap report query that doesn't require special expertise to run or configure, and also enables bulk action to be taken on the results of the query. There are participants in this learning community, in addition to the care delivery organizations who work with public health departments, who are looking to aggregate these results across many care delivery organizations for population health, public health purposes. And there's also a learning community focused on sickle cell disease that grew out of this pain and opioid community that's doing similar work for sickle cell disease. So the lessons learned is that there's a tremendous opportunity here for vendor and target agnostic care gap reports, but we're really a long way away from meeting those needs. So in the near term, we're going to keep having to sort of make this happen target by target, EHR by EHR. There is an overarching initiative, the Accelerating Care Transformation Initiative, that's going to be looking at doing this work in a more vendor and target agnostic manner. Next slide. Anybody who's interested in participating in any of these specific target-focused learning communities or working on this overarching issue of developing care gap reports in a vendor and target agnostic way through this broader initiative is welcome to reach out to me, and happy to discuss this more in the Q&A. Thanks.
All right, I'm Enrique from RPI, happy to be here. Surveys are studies that aim to collect data from a population largely by the use of questionnaires. And the one important survey in the United States is the NHANES, which is a series of surveys that is concerned about the US population's health and dietary conditions. So while the NHANES data is very well documented, this documentation is only human interpretable through the use of traditional data dictionaries. And this puts some pressure on the data user when performing data analysis, as they need to do several operations, especially when combining variables in the context of specific use cases. Our approach to this problem is to model the survey knowledge in a machine interpretable way, laying down the foundation for automated processes over the data. So for this, we employ the use of semantic data dictionaries, or SDDs, which is an approach to annotate and disseminate knowledge behind those data files. You can think about SDDs as an extension to the traditional data dictionaries that are machine interpretable and semantically enabled. We implemented this approach in a pipeline, a three-step pipeline, which first we use an R tool called NHANES, which allows us to programmatically access the NHANES metadata. And based on this metadata, we employ the same automated way of annotating those variables. We use two tools for this. One is the SDG-Gen, which is a machine learning-based model that should suggest ontology terms for natural language inputs. And the second one was the MCBK annotator, which is a more traditional approach using the ontologies in bioportal. The goal was to capture annotations from multiple sources and compare the stability and the agreement between both. So based on this outcome, we created SDDs in step 2 by combining the suggested terms, ontology terms, with human input. So SDDs allow you to not only annotate variables, but to further describe the knowledge behind the variables. So for example, you can elicit entities, the roles, metadata, such as time, location, and the relationships between the entities. We then use the SDDs in combination with the original NHANES data to produce a knowledge graph that materializes the knowledge behind the survey. So from this KG so far, we're able to implement a few semantically enabled data analysis in the context of few use cases that have an increased level of automation. So one is data browsing, which allows users to navigate NHANES data by referring to the semantic meaning of variables. And the other one was to produce new data sets according to user needs. For example, we were able to support an equity analysis about the access to diabetes medications across several demographics. This involved variable selection, variable combination, data normalization, alignment of code blocks, and this was greatly facilitated by this framework. Right now, we are expanding and refining the graph as we get some feedback from subject matter experts. And happy to have answer questions as you need. Thank you.
Hi, I'm Bruce Bray, a professor at the University of Utah and co-chair of the Learning Health System group within HL7. We wanted to just do a brief update of an ongoing project that we've had there using the Learning Health System virtuous cycle as a model to explore existing guidelines and the gaps and overlaps involved there. This this virtuous cycle comes from the HRQ ACTS project that Jerry mentioned before. The idea of having 4 quadrants of knowledge to action, action to data, data to evidence, and evidence to knowledge. And the idea of kind of an informal discussion of an inventory of existing standards, both inside HL7 There's lots of them there, as well as some that are relevant outside HL7, like OMG's BPM plus a group of standards that are relevant. And then kind of identify how where are the gaps and the overlaps in these standards. I guess next slide. So this is just a draft example of how parsing these into these different standards. Upper left, the evidence to knowledge groups like the EBM on Fire example. Upper right would be the guidance to action, like the decision support tools and workflow modeling kinds of tools. The bottom right, the action to data, like the quality reporting, the public health reporting, and so forth. And then finally, the data back to evidence in the more research-oriented things. And this is also relevant from the standpoint of the guideline development, but then also we have a number of accelerators inside HL7 that are working on actual implementation, and that implementation or delivering, mobilizing the knowledge is kind of a new focus of HL7. Next. So as I mentioned, the activities are around sort of looking at the gaps and overlaps, how to reuse sort of a desiloing process. Essentially, there's a number of different guidelines that use different information models within HL7, and trying to figure out how to understand those gaps and potentially enhance this virtuous cycle process. Currently in the process of outlining a publication to kind of present this sort of thing. And the next slide. There's just contact information. We have calls every Monday afternoon at 3 p.m. Eastern, and welcome to contact myself, Maria Michaels, Josh, or anybody, and to participate in this process. Thanks.
Hi everyone, my name is Yujia. My topic today is about development of mental health terms in human phenotype ontology. Next slides. The traditional infrastructures like DSM-5 and ICD is widely known diagnosis systems and is valuable infrastructures used by doctors to find diagnosis and implement interventions. But they also have some limitations. For example, they focus too much on diagnostic category and not enough biomarker involvement, and it's also difficult in handling disease heterogeneity. In contrast to traditional infrastructures, HiTop offering a more continuous perspective of the disease spectrum, and RDoc focus on brain functions. However, these infrastructures are not readily used in diagnosis, and it's hard to integrate into current systems like EHR, and it's also not good for representing psychopathological symptoms. So to address these issues, ontology, especially HPO, offers new possibility for standardization and comprehensive description of mental illness. Next slide. In short, like ontology is a representation or a language that can be understood by both humans and machines. In ontology, we use terms and relationships to build a structured knowledge framework. And now ontology have become a part of data and knowledge management. Next slide. HPO is a branch of ontology which focused on abnormal phenotypes associated with disease in humans. In the mental health section, it has already seen advances such as applications in genomic data integration, clinical diagnosis utility, and real disease research. However, there still have a lot of things need to do there because the mental health terms are confusing and unreasonable there, and it is still challenging in integrating into electronic health records or other systems. In our work, we are planning to build next slides. In our work, we plan to build a minimum information standard based on community consensus, which means we will work closely with mental health professionals, clinics, researchers. And in addition, we will add those terms that are missing in the current version. This includes refined classification of terms and the build of more precise relationships and attribute associations, and as well as symptoms and phenotypes not covered by current diagnosis criteria. We will also explore the possibility of combining HPO with other common data models to enhance interoperability and data sharing capabilities. And our ultimate goal is to construct a comprehensive mental health terminology that will help facilitate the implementation of a dimensional diagnosis system. Such system would improve diagnostic consistency and accuracy and be able to better account for comorbidity between different mental health problems. Thanks.
Hi, I'm Zach Landis-Lewis at the University of Michigan in the Department of Learning Health Sciences. I'm excited to share this work with you, which is focused on healthcare professionals who must learn continuously as a core part of their work. One tool for learning is feedback reports and dashboards that enable healthcare professionals to learn from their clinical data. But these tools tend to be underutilized and unfortunately ignored. Yet they're the primary way that clinicians can learn from their data to improve their performance. So our work is focused on using precision feedback. And I think there's something blocking the poster right now, at least from my view, FYI. So precision feedback is what we're calling this work of adding coaching and appreciation feedback messages to increase the value of this information for providers when they want to use it to learn to improve performance. So on the right side, you can see an example of a precision feedback message at the top of an email. The message says, you reached the top performer benchmark this month for this measure. This is an email that's been from a project we're working on to add these messages for anesthesia providers in a quality improvement network that sends out emails like this to more than 8,000 anesthesia providers across the country each month. So to enable a system to generate these messages, we've developed this precision feedback knowledge base that has a message library. And in the lower right corner, there's a collection on the poster you can see of precision feedback messages, statements like you've reached a goal, your performance has dropped. And to create messages like these and to select them, we have a knowledge base that contains both the message library as well as other models that we've developed. In the center of the poster, you can see a model of motivating performance information. And these are the features like comparisons, trends, achievements, and losses that we've understood are what healthcare professionals are looking for when they actually get to look at a feedback report or dashboard. It's what they're trying to find. And so we have annotation functions that use these models. And then the message templates and motivating information models are applied to an individual healthcare professional's performance data and scored using a causal pathway model that represents a approach to scoring the motivational potential of a message. So we've put this all together. We're developing it in public in a GitHub repository. There's a QR code on the poster you can use to access the knowledge base. I'd love to talk more with you about it. Thank you.
Wow, well, this is a fantastic series of posters. I want to thank each of you for presenting and sharing this really great work that you have underway. Maybe to get a conversation going among us all in this room, I'm curious as to what themes you all might see across the different efforts that you all have presented on. And do you see any commonalities? Or might you see important distinctions, differences, or gaps?
Interesting. From the standards perspective, there was a lot of metadata mentioned, and you already mentioned that tomorrow the standards group in MCBK will be talking about a metadata project been working on, and I think that really is common across all, at least many of these themes, to really be able to classify what's going on, chunk it into things, look at similarities and differences and gaps. That's kind of one of the things we've been doing with our HL7 project.
Yeah, Bruce, I think that's a very astute observation. I agree with it. I took note that there seemed to be some really fantastic work going around in data representation for knowledge management, and I'm curious as to maybe you, Jeff, if you've had an eye towards some of your work in thinking about how that could be translated into more standards-based efforts. Has that been part of your thought process as you've undergone your research?
Yeah, like for me, I think because I'm just like beginning with this project, so I think there are like a lot of like things to do, and it's because I'm focused on like HPO, like ontology. So ontology is like kind of like a representation, have a kind of language that can understood by both humans and machines. And also HPO is like a branch of ontology. So I think like the reason why I focused on HPO is because like HPO can be like have a lot, like have a great advantages about interoperability between different systems and different common data models. So which means they can like so they used really well in different systems or something.
Fantastic. Yeah, well, maybe the MCBK can be a forum for conversations that help to inform some of your work going forward as it develops, and it develops in line with some of the work or thinking that is underway within the standards communities. Nikki, I was very interested in the work that you and your team have done, and you mentioned as one of the action items some of the work that would be effective, be good to do it within diverse health settings. And I was wondering if you could say more about what your thinking or thoughts are around diverse health settings and what those would entail.
Sure. So we only examined 20 projects in our study. So we know that it's not a broad representation of all of the research that's being done in this area, but one of the things we found in terms of equity is that people were either really focusing on a target population, like Black or African American women, or experiencing X disease. And because they had this specific target population, they weren't able to do any sort of subgroup analyses to see any impacts or differences in health outcomes by race, ethnicity, or any other social determinants of health. So that's what we were discussing with key informants, is kind of the need for broader, diverse groups, larger samples in order to be able to get to that point to measure equity.
And Penny, for your thoughts as to how you might go about achieving that in getting some of these PCCDS interventions into the hands of more diverse communities and settings.
Oh gosh, that's a big question. I think it would just go back to the types of projects that are funded, and the difficulties of conducting PCCDS in rural communities where they do have technical challenges with Wi-Fi and access to internet, even within healthcare settings. So I think it's a tough question. I think there needs to be more of a call for action in funding mechanisms to get those into broader settings.
Fantastic answer. Thanks for your observations and insight. Jerry, I see your hand is up, and as Nikki was talking, I was also thinking about public health as being an area that could be ripe for investigation. But anyway, but it's thinking about some of the work you've been doing with ACT. But what are your thoughts? What are you thinking?
There we go. I actually have a question for you, Josh, as both a co-author on our poster and one of the organizers for this conference. So I think our poster sort of, made the point about how assessing care gaps is really critical, and we need, computable, interoperable approaches to doing that. And it would seem like MCBK as an organization could and potentially should be a player in helping us get from where we are now, where this is done EHR by EHR and target by target, and doing it in a way that really mobilizes computable biomedical and knowledge. So I know this is sort of putting you on the spot. I'm not expecting a well-formed answer, but one of the questions that I've been having all along is whether and how MCBK and the work groups in MCBK and what MCBK North America is trying to do in particular, what the opportunities are for synergy between where MCBK is going and the kinds of challenges and opportunities that we talked about in the poster.
Yeah, I think that's a fantastic question, Jerry, and not to punt too much, but yeah, I think tomorrow we'll definitely be able to get very much into the weeds in terms of what is MCBK, how can it be of value to the community, and I think that this is an area that's very near and dear to my heart in terms of being able to generate, make computable guidelines that can be implemented and have measurably improved care and care outcomes. And so I think that closer coordination among efforts like yours, maybe like CDSIC, and this is just me getting on a little bit of a soapbox. So this is me for that matter. And the HL7, I think that there might be some ways, and maybe we can bridge build some bridges between these different communities. Maybe MCBK is that. I hate to have yet another meeting that people attend, but maybe this could be a catalyst for the kinds of conversations that build that not only identify the areas of need, whether it's diverse health settings and diverse communities, to the areas of care that you've been looking at, Jerry, pain and opioids or sickle cell, and aligning that with HL7, which I think, Bruce, don't let me speak for you, could and is working more through the Learning Health System Working Group to align standards within a learning health system framework, which and so that I think that takes a different shift in thinking in terms of how standards then align within the rapid learning health cycles that move data into knowledge back into data, and doing so in ways that metadata can support the life cycle of knowledge and data as it's used to improve care processes and care delivery. And so I maybe that conversation, we can extend that tomorrow, but that's kind of where I'm at currently. I don't know what your reaction is to that. I also see that there's a question in the chat that I think is apropos to Bruce in terms of the goal, and especially the word virtuous LHS. Maybe there's alignment there in terms of some of what I've had to say.
Yeah, I can take a stab at that, and Maria Michaels, if you're still on, could jump in too. The idea, well, the HL7 has got a couple dozen work groups and a dozen accelerators, and then there's OMG, and there's WHO and X12. There's lots of I can't remember who said that great thing about standards, there's so many to choose from. they all tend to be siloed somewhat. That's the way you get something done, is you actually focus on one task, do it well. But then when that task has 80% data overlap with the next task you want to do, say that's kind of what we were meaning by the taking this virtuous cycle idea, that things start with data, you analyze the data, create into information or evidence. That evidence then gets turned into practice guidelines or knowledge, and that potentially is computable. Then that computable knowledge can get delivered through decision support to the point of care. Then once you deliver that, you measure the results. It turns back into data, and that data then drives the cycle again. That's kind of what we meant by that virtuous cycle approach. And there's plenty of silos that when we started thinking about this from that quadrant perspective, we saw that there's plenty of silos. Even just taking evidence-based medicine on fire, the EBM on fire models for literature getting turned into knowledge, and then the clinical practice guidelines on fire, which is to take the mature version of that to deliver to the point of care, and then how you measure the outcomes of that as quality reporting. They're different data, different information models, and so you continuously have to kind of try to de-silo that. So it's clearly is an issue, and how to best do that. Maybe modeling that, put it tagging with metadata these different things, and identifying these overlapping guidelines or overlapping implementation guides that have different information models, and then negotiating how to fix that. Doing that, HL7's gotten a little better at doing that. We have projects with OMOP, we have projects with BPM Plus and others outside of HL7 to try to make sure that we're kind of de-siloing that world, and that's kind of the perspective that we were taking there. I don't know if Maria has anything else you wanted to add.
No, I think you covered it pretty well. If I were to just sum all of that up, it's really thinking about that whole data to evidence to knowledge to action back to data, and thinking about how the standards can help support it. And as Bruce mentioned, how we can align information models as best as possible so that that information flow is as seamless as it can be.
Thanks. Thank you all. That's fantastic. We have 2 minutes left in this group. I feel so bad that I have other questions here for Zach, for Enrique. Maybe Powell, in the last couple of minutes, I'm curious on that data to and evidence into action piece. How is it that you're going about implementing what you presented, and what is it, and how are you implementing it, and what impacts are you seeing within real world care?
So this is Pawan. Maybe I can take that question. So our biggest challenge has been data acquisition, going to hospital and asking them to provision data. And second, making sense out of data. 60 to 80% of emergency medicine data is in some form of text that has to be abstracted and standardized and normalized. Once we are able to do that, then the next thing is to create evidence out of it. So the goal is to really speed up the process of evidence generation from 17 years to maybe 3 years, 5 years. We were able to do that during COVID period, where ACEP published the first field guide within 3 weeks and then updated every 3 weeks. That was used globally in 195 countries to treat COVID and diagnose COVID. So based upon that, we are trying to build more AI tools. We are trying to look into natural language processing engines and work with communities like, MCBK as well as BPM Plus to make sure that the documentation practices are standardized as well.
Thank you so much. I want to thank you all again very much for this opportunity to view and the work that you all have been embarking on. And I feel enlightened. I feel like I've come away a lot wiser from having seen your presentations. And I just want to thank you all so much for sharing. Great work. Thank you so much.